Hello, everyone, and welcome to our value-based purchasing interim performance reports webinar. We have scheduled 1 hour for this webinar today. We want to welcome all of you who are joining us for the first time. My name is Melinda Gaboury. I am CEO and co-founder of Healthcare Provider Solutions. We are celebrating just over 22 years of being in the home health and hospice industry. Where I primarily, most of the time anyway, are providing education and providing education across the nation. So today we are going to get into the value-based purchasing reports, and we're going to begin with where you get them. Your value-based purchasing reports will be found in the iKeys spot where you would normally access your CASPER reports and or the final validation reports from where you have transmitted OASIS. You do want to make sure that you have multiple people with logins into this system, so as someone always has access to the data found in this system, and you do have to go through a process, of course, of registering people in that system. This is just more information. It tells you to exactly specifically look for HHA provider preview reports when looking for these reports. Do remember that there were pre-implementation reports. There were 3 installments of those, and that was prior to them obtaining the achievement thresholds and benchmarks from our true baseline year of 2022. And so make sure that when you're looking for the current reports, you're looking for the ones that were released in July of 2023 that are the first interim reports using the new information. So there is one for every CMS certification number or Medicare provider number. So if you're a member, your agency is a member of an organization that owns several home health agencies, if every single provider number that your organization has will have their own individual report. There's no, quote, corporate entity reporting. And the results, as far as how they are calculating your payment results of the value-based purchasing performance year 2023 will also be per provider number. So every single individual CMS certification number, provider number, et cetera, all of those, just different titles for the number, are going to have their own individual reports and own individual calculations. So this is the beginning of the new information based on the achievement thresholds and benchmarks for our baseline year of 2022. Keeping in mind that the reports I referenced a few minutes ago that were the pre-implementation reports, we're using 2019 data because they didn't have the achievement thresholds and benchmarks yet released for the true baseline year of 2022. They had initially told us that they were going to use the 2019 baseline year, and then they changed their mind and are officially using 2022 in our current comparisons. So some people have been a little frustrated to find that the first implementation reports didn't exactly reflect their status or where it looked that they were going to be based on the pre-implementation reports. But the reality again is they were using a completely different baseline year, and they had full achievement thresholds and benchmarks to compare to. And as we began the current performance year, there is so much data that still remains in the calculation from 2022 comparing to its own baseline year of 2022. So you'll make sense of that, I think, as we go through the reports. I didn't say earlier, but I will now. If you have questions at any point during this presentation, please type those in the Q&A box at the bottom of your Zoom window. Please do not use the chat. type those into the Q&A box. So when we look at these achievement thresholds and benchmarks, you need to realize exactly what these mean and what they mean for you as far as determining how they impact your calculations. The achievement threshold is basically the 50th percentile of scores of all the home health agencies in your cohort for the baseline year. And so just in case anyone on the call today is new to the party of value-based purchasing, the small versus large cohort is simply defined as the small cohort involves any home health agency that has not seen at least 60 unique beneficiaries in the given year, establishing your status for 2023. The large cohort is all other agencies who are required to participate in HHCAPS and have done so. So as you see in the achievement threshold and benchmark columns of the small cohort, there are no scores for the HHCAPS surveys because you're a small enough agency, you're not even required to do them. So that changes the calculation for those participants in the small cohort, that the claims data and the OASIS data are now 50% each of your total performance score instead of the 35 and 30% that they are for the large cohort. And so when we're looking at these numbers, what do we need to take from this? So as you will see in a moment, there are two calculations made on your current 2023 scores, the achievement calculation and the improvement calculation, and you get the higher of the two scores. So when we're looking at the achievement threshold, this again represents the 50th percentile of scores in your cohort in the baseline year. If your scores for the current year 2023 are not at least as high as these achievement thresholds, you will not get a calculation for achievement. You will automatically get 0 points. So having said that, if we look at the very first item, discharge to community, the achievement threshold for the large cohort is 72.652. If your score is not at least 72.652 or higher, you will not get a score for achievement in the total performance score calculation. You will automatically get 0 points for achievement. And then they make the improvement calculation, which we'll talk about in a few minutes. Then we have the benchmark, as you see on the screen. That's what I call the high, lofty goal of agencies, but it basically represents the 90th percentile of scores in your cohort, or the top 10 percentile of actual scores. And so the benchmark, again, that high, lofty number to shoot for, but in most cases, you're not going to hit that in all of these. If any agency hit the benchmark in every single calculation, I'd be a little concerned. So the reality is, if you ever hit the benchmark, so if discharge to community, for example, if you're in the large cohort and your score in discharge to community is 84.249 or higher, you automatically get 10 points in the calculation of the total performance score, and they don't even have to make an improvement calculation because you automatically get 10 points. So basically, in a nutshell, your score for 2023 needs to be at least as high as the achievement threshold in order to get a calculation for achievement. If it hits the benchmark, you will automatically get 10 points. Same is true for the small cohort. You just simply have different numbers in the achievement threshold and benchmark based on your small cohort participation. So the achievement calculation is found on the screen. This calculation basically takes your current year performance score. Anytime you see the term performance score in value-based purchasing, they're talking about your current year calculated score. They subtract from that the achievement threshold, which we just reviewed, divide that by the great big lofty benchmark number minus the achievement threshold. The result of that is multiplied by 10, and you get the resultant score. Achievement is a maximum of 10 possible points, while improvement is maxed at 9 points. The maximum of 9 points for improvement is for multiple reasons, but primarily during the 5-year value-based purchasing demonstration in home health that ended in 2020. That demonstration, in the 4th year of the demonstration, they made significant changes to the calculations of the demonstration. And in those changes, one of the things they changed was the maximum points for improvement being 9 points instead of 10. They did that because so many agencies in those states, participating states, came into the value-based purchasing demonstration having very poor scores from the baseline year. And so they get into the value-based purchasing demonstration, they realize how impactful the results are going to be on their reimbursement. They decide to start paying attention, and they start getting these huge improvement scores because their first year scores were so much better than the baseline year. And so because of that, again, they were getting these huge improvement scores, and the agencies that had been already working so hard on positive outcomes and star ratings, etc., had very little room to show dramatic improvement because they were already practicing at a very high level. And so CMS realized the situation there. One of the other issues there was the reality that 2015 was the baseline year. And so 2016 was compared to 2015, and all that improvement that was shown in 2016 only counted for 2016. So when we get to 2017, they're again comparing all the way back to the baseline year of 2015. So those improvement scores, they got to see huge improvement scores yet again. And so they were trying to curtail, for lack of a better term, a little bit, the situation with the huge improvement scores. And therefore, the reason why they changed the maximum points for improvement to be 9, and that continues today in the nationwide expansion. So we're going to get now into the details of the new reports, talk about the content of each of the tabs that are included in that document that you've downloaded for your reports, and discuss how you should be interpreting them and what you should be doing moving forward in order to maintain or improve your scores. So this tab is the table of contents tab, and basically just outlines everything that you're going to see within this report, giving you your achievement points, your improvement points tab, your care points tab, the scorecard, the total normalized composite change reference, your achievement thresholds and benchmarks, which we just looked at. And then there's a resources page that we're not going to review. But all of these other pages we are going to review. Again, make sure you keep in mind that every single individual provider number is addressed in these reports individually. So if you do have multiple numbers, you will want to make sure to pull every report. So this is the overview tab that gives you just the detail of your agency at the top with the CCN number, specific CCN number, and then gives you the dates that this report includes data from in the calculation of the scores at this point. Keeping in mind, as you see, the claims-based data and the HHCAPS data is only for the 2022 year. So when comparing those to yourself, you're not going to be able to show improvement because those scores are going to be identical. But at this point, if your scores in 2022 were higher than the median or 50th percentile of scores for achievement, you should have been able to glean some achievement points. And we're going to look at those as we get to the achievement scores. The OASIS-based data, we do, at this point, show 3 months of the current year. in the calculation, but we still have 9 months of 2022 dragging along, for lack of a better term. So it's hard to grasp at this point where you technically really are, but everybody in the nation is in the same position, obviously. Some of you have software systems that you're utilizing that are trying to get data as you go, live calculations, and give you the information you need to help stay as current as you can as far as where your position is in the nation. But do understand in reviewing that data, you need to ensure all the pieces of the puzzle are there. And if that software vendor doesn't have access to the entire nation's information, then it's going to be a little skewed as well. So just keep those in mind. So this is the achievement tab within your reports. The achievement tab gives you the recap of your achievement points after that calculation has been made, again, assuming that you reached the achievement threshold for your cohort. So in this agency's calculations, as you see, it again tells you the dates. This is a 12-month period always. The OASIS data ending March 31st, and then the rest of the data going through 12/31/2022. You then have your current year scores, keeping in mind that the current year scores for claims-based data and for HHCAPS is still all of 2022. But the top one with OASIS does go through March 31st. So you should have that first quarter of OASIS outcomes utilized in the calculation of these reports. Then it gives you the achievement thresholds, which are the exact same numbers we saw on the previous screen. As you can see, this agency does exceed the achievement thresholds in each of the OASIS items. In the claims data, these are backward, of course. In the claims data, you want the acute care, hospitalization, and emergency department scores to be small, not large. So you want those to be less than the threshold, not greater than the threshold. And so in the case of the acute care hospitalizations, this agency is less than the achievement threshold at 13.465 versus 13.907, where their emergency department score is higher. So they will get 0 achievement points for the emergency department, as you see in that fourth column of scores. And in the achievement column, they actually do get an achievement score because their acute care hospitalization is less than the 50th percentile achievement threshold. When you look at the HHCAPS surveys below, every single one of their scores, which again are based solely on 2022, are less than the achievement threshold 50th percentile of scores for 2022. So they get zeros at this point for achievement for every one of the HHCAPS scores. So the OASIS scores you see at the top, they exceeded the achievement threshold for each one. So they got an achievement calculation. And then this last column simply tells you that the maximum points for achievement is 10 points. The improvement scores, the OASIS data, if you did at least as good as you yourself did in 2022, in other words, you exceeded your improvement thresholds, then you will have a calculation for improvement. In each case, again, this data going just through March 31st of 2023, the agency has in each of the OASIS measures exceeded their own scores from 2022. And that means they are definitely headed in the right direction with improvement in their OASIS items. And they do get improvement calculations for each one. Now, when you get to the claims-based data and the HHCAPS data, they cannot have improvement scores at this point because all of the scores for the current performance year are based on 2022, and your improvement threshold are your 2022 scores. So it's impossible for any agency to have improvement scores at this point for 2022. But as you saw on the previous screen, if your 2022 scores exceeded the 50th percentiles of scores in the nation, then you did get some achievement points for those items, but nobody can have improvement points in claims data or HHCAPS data at this point. So the next tab in these reports is called the Care Points tab. This is simply a recap of the two screens we just looked at, which is a summary of your achievement points, where they have calculated your achievement scores when you had scores that resulted in an achievement score. The same for improvement. So as you see again, in improvement, all of your improvement scores are 0. In the achievement column, for each of the items where your current year score exceeded that 50th percentile of the nation or of your cohort, you did get an achievement score. And so this will continue to be the same, meaning this compare Care Points tab will continue to compare points as we go through this whole process of getting this year's scores, giving you your achievement scores, your improvement scores, and then in the next column, the HHA's Care Points column, you will get the higher of the two. So in the OASIS items for this particular agency, every single one of their OASIS items had greater achievement points than they did improvement points, which means their calculation based on their scores compared to their peers were higher than comparing their scores to their own scores in 2022. Now that may swing for some agencies as we continue to get additional reports in the near future. Because of the fact, again, in these improvement scores, you only have 3 months of data involved in that calculation for the first 3 months of 2023, comparing it to 2022's improvement information or score information, which is composed of 9 months of that year. So the acute care hospitalization and emergency department, the only scores you're going to get in that section, this agency at all, is the achievement points for acute care hospitalization. Now, the next column of numbers, and of course, those care points are totally summed at the bottom at 13.23. Then we go to the last column, and this is an important column, but I don't want you to be misled by this column either. So this column, as you see at the very beginning, the discharge to community score for this agency at 7.513 is in the greater than or equal to 75th percentile of their cohort. That's a very, very good place to be. So that basically means that they have superseded basically at or above the 75th percentile. In order for you to be positive in the reimbursement calculation of value-based purchasing in the end, your overall total performance score has to be at least in the 51st percentile. So to have an item that's already in the 75th percentile, assuming you continue at that level or higher, then you're knocking it out of the ballpark in that specific item. You get to the next item, which is improvement in dyspnea, and you see their score there is ranked in the 25th to 49th percentile. Definitely not a place that you want to be, but obviously better than less than the 25th percentile, right? So at least you're between 25 and 49. At this point, it's kind of hard to know exactly where we are in that scoring. Are we close to the 26th percentile? Are we at the 49th? And almost 50, hard to really judge at this point, but we know we're not at the 51st, right? So that is definitely on your list to look at for improvement when you had any of these items that are between the 25th and 49th percentile. Then we get to the 50 to 74th percentile, and we don't want to truly sweat these too much. But I will tell you this, we were just reviewing earlier a report from one of our clients where they were between the 50th and 74th percentile on all of the items that they had scores for in the first IPR reports that we're looking at. And they had one single item that was in less than the 25th percentile. Their overall total performance score was in the 25th to 49th percentile. My point in telling you that is, even if every single one of your items on the list are currently in the 50th to 74th percentiles, that doesn't necessarily mean you're in the positive world of the calculation of payment. So be very aware that your overall total performance score is going to need to be in at least the 51st or higher percentile in order for your result, bottom line result, to be positive. So just because, again, you see these scores, some of these scores in the 50 to 74th percentiles, doesn't mean that you can necessarily say, we're doing great there, we're fine. If you're over the 75th percentile, you shouldn't have a worry. But if you're in the 50 to 74th, but that one individual item is only in the 50th technically, which means you just barely squeaked in, that score may not be high enough in total to get you into that 51st plus percentile overall in order to get a positive payment result. So this is the Scorecard tab where it gives you the calculation of your total performance score. And it's basically taking your care points from the previous page. So again, that's taking achievement, improvement, comparing the two, giving you the higher of the two scores, and that's your care points. And as you see, they're from the previous page, and the sum of those measures is 13.230. This is the total performance score information here and the percentiles at the bottom, but we're going to go to the next screen where I've made that top part of that screen bigger so you can read it easier for the presentation. So the care points in this column, this just gives you the maximum number of points that you can receive for the total points, and then the measure weight. So if you're in the large cohort, your measure weight, as you see, 5.83, 8383 for the first three OASIS items, and then 8.75 for the next two, with a total of 35% of your total score being from the OASIS-based items. And then the two claims-based measures, 26.25 for acute care hospitalization, 8.75 for emergency department, 35% overall. And then the HHCAP scores are 6% each for a grand total of 30% of your grand total score. Now, what you have to hear is we are still, excuse me, in this calculation, they are still taking into consideration that for the HHCAPS measures, this agency has 0 points in the total performance score calculation because their scores in HHCAPS were not at least as good as the 50th percentile of their cohort in order to get achievement points. No one's getting improvement points for this particular implementation reports because, again, you're comparing 22 to 22 against yourself, and that's going to be a net 0. But if this agency had had HHCAP scores that were higher than the achievement thresholds, again, representing the 50th percentile scores of their cohort, then they would have had scores here to add in as the additional 30% of their score. So basically 30% of their total performance score is 0 right now. 35% of their total score is 1.893, which is acute care hospitalization. And then 35% of their score is 8.109, which is their weighted measure points for the OASIS items. The grand total of their current total performance score is 10.002 out of a possible 100. So we see here their interim score 10.002. That is their total performance score, and they are in the less than 25th percentile of their cohort, which definitely at this point, if they were going to calculate reimbursement impact for the future years, this agency would definitely be in a negative situation, meaning there would be a percentage of reduced payment added to each of their payments in 2025. Hopefully, as this agency continues to progress through the year, they will be able to improve those scores. Now, you need to keep in mind that we're already in September right now. So we are almost 3/4 of the way through the year, and some are just now getting access to these reports and finding out where they stand. But then after the OASIS data for March 31st and the HHCAPS data for the end of 2022, we don't have anything, but we've already done what's going to be done, and the outcomes are already going to be calculated for what we've done through this point. My point being, whatever you've seen in these reports and any live data you can gather from any software systems that might be trying to assist you in keeping up with your VBP scores, you need to be working diligently to ensure that your scores continue to improve. The improvement threshold that you saw on the improvement page is your scores from 2022. You have to ensure that your scores this year are at least as high as your scores from 2022 just to get an improvement score. But if your scores do not supersede the achievement thresholds, which are again the 50th percentile of your cohort, then it's a little concerning as to whether or not you're going to be able to get to that 51st percentile of scores. Hopefully that makes sense. Please ask questions if not. So the total normalized composite change reference tab is this tab where it is taken the total normalized composite change measures in mobility and self-care and has broken those down into the individual OASIS items. Now, the thing you need to know about this report is that it does not, it is not risk adjusted. It is simply information. But is it good information? Yes. So if you look at the total normalized composite change in mobility measures, you see that this agency's percentage where they had no change in the patient's condition. And then the next one is the percentage of their patients in this calculated time period that had a positive change in their patient's situation and then negative change. And then it gives you the average for their agency's cohort. So while this information is not risk adjusted, it does at least give you information for you to know how you compare to your cohort in making a positive change in your patient's situation as you're looking at the completion on the OASIS. Again, these are not comparing apples to apples when you look at these percentages and then compare them to your scores on the previous screens, but it does give you some insight into whether or not you're at least doing as well as these other agencies in showing a positive change in your patient's condition based on your OASIS responses. So hopefully that makes sense and is helpful. So this screen is the resources tab that they have provided. If you click on this link at the bottom of the screen or you go to that link, this is the value-based purchasing page on the CMS website where there is unlimited amounts of information. One of the things you absolutely have to do at that link is go and register for the email notifications regarding updates to the value-based purchasing model expansion. It also, there are newsletters that they are producing specific to value-based purchasing. You need to be enrolled to receive those. There is educational videos. There are educational videos, etc., found on that webpage as well. That will help you through understanding the value-based purchasing model and exactly how it works. Now, the last thing we're going to cover today are the proposed changes to the value-based purchasing model that will begin in 2025. Now, for those of you who came to this call today to specifically hear about the IPR reports, if you have any questions about those reports, please don't hesitate to type those in the Q&A box, and we will definitely get to those questions in a few minutes. I also don't want you, if that's the only reason you came here today, to leave right now, because these proposed changes for the model are going to have a baseline year of 2023, which is now, which I'm trying to convey means that you're not going to be able to forget about these proposed changes, which are going to be finalized with this final rule. We feel confident they will be finalized because you can't just start thinking about them in 2025 or even at the end of 2024, because they're going to be compared to a baseline year of 2023, and that's today. So having said that, the proposed changes include that they are going to remove 5 of the value-based purchasing measures that we just reviewed. They will be completely removed from value-based purchasing and replaced by 3 new ones. They're going to update the weights for all the measures except for HH caps, the HH caps surveys. The questions are going to stay the same, and the percentage of impact they have on the total performance score are going to remain the same in 2025. And then they're codifying how they're going to remove factors. And again, they're changing the baseline year to 2023. So currently today in 2023, our baseline year is 2022. When we get to 2024, the baseline year will still be 2022. And when we get to 2025, the baseline year will become 2023, which is the current year we are in today. Another thing you need to make sure you're aware of that many haven't really caught on to yet, and that is they are going to begin publicly reporting the value-based purchasing data and payment adjustments that you're going to receive starting in December of 2024. So as a result of your current performance year in 2023, you will continue to get interim reports. And then in October of next year, you will get the final report for 2023, including the payment adjustments. You'll have a slight time to appeal, and then the final will be issued in November, affecting your payments in 2025, and they are going to publicly report that in December of 2024. So anyone in the nation will be able to access that data and see how your agency fared in value-based purchasing and what kind of a payment adjustment you're going to receive as a result of how you fared in 2023. So this is the sheet that shows the changes that are going to occur in the OASIS and claims data. The dyspnea and management of oral meds items will remain on the value-based purchasing model. The only change to them will be the weight of their impact on the total performance score will be changed from 5.83% to 6% for dyspnea and 9% for management of oral meds. The discharge to community item that is currently in VBP that is directly calculated from OASIS will be removed from the value-based purchasing model, and it will be replaced with the discharge to community post-acute care calculation. And I'm going to show you what that is in a few minutes. And that will be a 9% impact on your total performance score. The emergency department use and acute care hospitalization measures, as we know them today in value-based purchasing, will be fully removed in 2025 and will be replaced by the one new measure, which is already implemented in the home health quality reporting program, which is the home health within stay potentially preventable hospitalization measure, and it will be worth 26% of your total score. Currently today, acute care hospitalization and emergency department are a combined 35% of your total performance score. This one hospitalization item will be 26% of your total performance score, keeping in mind that the discharge to community post-acute measure is going to represent 9% of your total performance score, and it is now a claims-based measure where the current discharge to community measure is OASIS-based. And then lastly, at the bottom of the screen, the total normalized composite change in mobility and self-care measures are both going to be completely removed from value-based purchasing and be replaced with a one discharge function score, and that will represent 20% of your total performance score. This item, which technically will be based on OASIS, will not be based on the 1800 section. As of January 1st of 2025, the 1800 items on the OASIS document will no longer impact the value-based purchasing outcome calculations. And I will show you those, what's going to replace them in just a few minutes. This is the discharge to community post-acute care measure information as to how it will be calculated. This is a claims-based measure, as I said a minute ago, which is assessing the successful discharge to community from a home health agency, with successful discharge to community including no unplanned hospitalization or no death within 31 days following discharge. Specifically, this measure reports a home health agency's risk standardized rate for Medicare fee-for-service patients who are discharged to the community following a home health stay and do not have an unplanned admission to an acute care hospital, long-term care hospital within 31 days following discharge and who remain alive during the 31 days. So basically, what they're saying here is they want to know what percentage of your patients were discharged to community live and did not die or did not get admitted to an acute care or long-term care hospital in the next 31 days. We have no idea when we discharge a patient that they're going to go have a stroke 2 days from now, etc. But the reality is we're going to get dinged for it if it happens. So there are some exclusions. Obviously, pediatric patients won't be counted. Discharges to a psych hospital don't count. Discharges against medical advice don't count. How they're going to track that specifically, we're not sure yet. Discharges to disaster alternative care sites or federal hospitals, discharges to court or law enforcement, discharges to hospice will not count, which is a good thing, right? So if the home health agency discharges the patient live, but they're discharging them to hospice or transferring them to hospice, they will not count against you if that patient were to die in the 31-day window. Stays for patients without continuous Part A or Part B fee-for-service in the 12 months prior to the home health admission and 31 days after. Home health stays that were preceded by short-term acute care or psychiatric hospital for non-surgical treatment of cancer. Stays ending in transfer to an agency. So if you transfer to another home health agency, they won't count. And stays with problematic claims data, which is, who knows. And then anybody whose Medicare benefit Part A is exhausted. Those will all be exclusions from the calculation. The next item is the home health within stay potentially preventable hospitalization measure. Any of you that are deeply involved in the home health quality reporting program monitoring know that this measure is already there. It is the measure reporting a home health agency's level rate of risk-adjusted potentially preventable hospitalizations, and get this, or potentially preventable observation stays that occur within a home health stay for all eligible stays at an agency. And then, of course, there are exclusions to that item as well. One of the best exclusions is stays that begin with a low utilization claim, which means if your first 30-day payment period of a home health admission is a LUPA adjusted claim, it will not count in the PPH calculation. Also excluded, stays where the patient receives services from multiple agencies, and stays where the information required for risk adjustment is missing, and the information below is the information required for risk adjustment. The last item, which is the one that should be the most eye-opening to you, is the discharge function score that I said will be replacing the total normalized composite change measures in self-care and mobility. The total normalized composite change measures currently, again, based on the M1800 items, this discharge function score will be based on the GG items from your OASIS. Now, the GG items in the OASIS have been on the OASIS for a few years, but have had no direct impact on reimbursement, have had no direct impact on outcomes, have been involved in risk adjustment to a degree, but that's it. Also note that in the current discharge to community calculation, they are calculating the patient's situation upon admission to the patient's situation at discharge, which happens with all these outcome measures, right? And the discharge one is should not even have mentioned it. The 1800 items is what we're talking about. And so when they're calculating that functional result, they're looking at what you said the patient's status functionally was in the 1800 items at the start of care, and calculating whether you're showing a positive change or not in the patient's condition based on your responses on the OASIS at discharge. So comparing again in the 1800s, what you said at start of care to what you said at discharge. Well, this is different in the GG items. You would think that they would take what you say at the start of care with the GGs and compare that to what you say at discharge. And that is technically not how it works. So this new item, the numerator being the number of home health episodes with an observed discharge function score that is equal to or higher than the calculated expected discharge function score. So what in the world is that? So some began to believe, and honestly, I sat in a session at a conference where a consultant stood on stage and told people that they were basically going to compare what you said about the discharge goal of the patient at the start of care to what was actually reality at discharge. And that is not true. What they're going to do, and they've already published the information, but they're going to take what you say the patient's status is on the GG items at the start of care or resumption of care, and they're going to put that information in an algorithm, and the algorithm is going to calculate what the patient's discharge status should be based on what you said their status was at the start of care. And then when you discharge the patient, they're going to take what you say is the patient's status on the discharge OASIS and compare that to what their algorithm said should have been their discharge status. And then you're going to get a calculation that determines if you were able to meet or exceed what the algorithm said your discharge status should be. And so people in sessions where I've taught this live have immediately begun to ask, have they released the algorithm? Have they told us what we're going to do? Have they told us what this is going to be? And the reality is, yes, they have released the algorithm. And if they believe that EMR systems and software vendors are not going to already begin developing this algorithm so that you as a home health agency will be able to take your Started Care Oasis and put the status of that patient at Started Care into this algorithm and determine what the discharge status should be, and then compare that to your Discharge Oasis. They're crazy. I mean, why would they think we would not do that? And so obviously that's what's going to happen. But for those that don't get ahead of the horse, or gets the cart ahead of the horse, they're going to be in a really bad situation when they wake up and realize what this calculation is doing. So again, they're going to take what you say the patient's status is on these GG items at the beginning, put them into an algorithm to determine what the discharge status should be. And then they're going to compare what you say it is at discharge to what they said it should be. And you get a positive outcome if your discharge result was actually as good or better than what their algorithm said it should be. So my biggest concern with this, honestly, is the lack of education that we have experienced happening in home health agencies across the nation in specific regard to the GG items. GG is very misunderstood. It has had very little education on the down and dirty field staff level, and has been ignored for the most part in the QA process of many organizations. And that's because it does not have a direct impact on outcomes. It does not have a direct impact on reimbursement until now. And so I emphasize this because, as I said a few minutes ago, this does not go into effect until January 1st of 2025. But if you wait until then to do something about it, you're going to fail. And it's going to be very, very ugly. So you need to begin that information immediately. They will be excluding some calculations from this. Patients who have an incomplete stay will include patients who are unexpectedly discharged to an acute care setting, patients who die, or patients with an episode that's less than 3 days. So if you discharge a patient from your agency to an acute care facility, and they're discharged, not transferred and resumed, but discharged, they would not count. A patient that's in a coma, vegetative state, etc., patient that's a pediatric, or patient that is discharged to hospice. So again, if the patient is discharged to hospice, this discharge function score will not even be calculated for that patient. I do have a question that says, so if we discharge a patient to Part B therapy, that will hurt us with the new proposed update. If we're talking about the discharge to post-acute stay, is that, I'm not exactly sure where we're talking about Part B impacting the patient. If the patient is discharged live to the community and they're not admitted to an acute care facility, or they're not admitted, or they don't die in 31 days, then we're okay. So if they're discharged live, but they participate in Part B therapy, there should be no reason why that would be a negative impact on you, if I'm understanding the question correctly. Okay. So we have another question that just came in. What payers are included in the home health within stay potentially hospitalization score? Medicare only, Medicare HMO, or Medicaid HMO. So the potentially preventable hospitalization measure is a claims-based measure, so it should only be traditional Medicare. So that is a really good point to acknowledge. Any of the claims-based measures should be solely based on your traditional Medicare claims, because CMS does not have access to all of the Medicare Advantage, Medicare HMO, etc. claims, or Medicaid claims. Even though you are required to transmit OASIS on all patients starting January of 2025, this is a claims-based measure, and should only be impacted by traditional Medicare claims? Very good question. We do have a couple of minutes for other questions if you want to type those in. We did get another one. Will a sick OASIS or significant change in condition OASIS affect discharge function score? The patient declines for some reason. If we do a significant change in condition, will a discharge function be calculated from start of care or from the sick? The calculation of outcomes is going to be from start of care to discharge, resumption of care to discharge. So if you do a significant change in condition, which technically is an other follow-up, the other follow-up OASIS might impact reimbursement as far as PDGM is concerned with the functional scoring, but it would not in any way impact outcomes. The outcome will be calculated from the start of care to the discharge or from a resumption of care if the patient is transferred and resumed to discharge, just like the current outcome measures in the star rating. The next question, when your OASIS is going to be submitted for everyone, did you mean all insurances? The new regulation requiring OASIS to be transmitted for all, effective January 1 of 2025, includes all patients regardless of the payer. And they're doing that because we are to eventually be able to calculate outcomes across the entire acute care continuum. And in order to do that, we have to be assessing patients just like the skilled nursing facilities, et cetera, are assessing patients. And skilled nursing facilities have had to discharge to community from day one. They have had to report OASIS or MDS on all patients, regardless of the payer from day one of MDS. And so now they're going to make us do that for OASIS. Okay, there's some language in the Q&A about the Part B question that I'm not going to elaborate on, but there is some more information there. Any other questions? Excuse me. If there are no other questions, we're going to let you go. We'll thank you all for participating in our webinar today. Healthcare Provider Solutions is here to help if there is anything we can ever assist you with. Have a fabulous day, and the next reports for value-based purchasing should be released in October, and we will likely do another webinar to review those in January. Thank you all again for participating, and have a fabulous week.